Good afternoon. This is Dr. Cindy Herndon, and I'm going to be presenting Chapter 16 of the McKinney text on giving birth. And these are your learning objectives. More learning objectives. And we're going to talk about issues for the new nurse. And so just jumping in here, the care of women and their families during labor and birth is very rewarding for the nurse. Birth is more meaningful than just the physical birthing process. It has deep personal and social significance for the whole family. Family roles and relationships are changed by the birth of a baby, and they're changed forever because this baby is going to bring deeper meaning into the lives of the mom, the father, the grandparents, and just the family as a whole. Working with people in pain, though, is difficult. It's a difficult task because most nurses feel compelled to resolve pain for the patient and very quickly. And this is going to be a different kind of task for the nurse and especially for the new nurse. Pain is an expected and necessary part of the labor process. We say in childbirth classes, we say no pain, no gain. So the pain that is accompanied with labor for most women is connected to the cervical dilation and effacement. So the pain, that's the cervical dilation and the effacement causes pain, and that is the process. So that's what we're working with. We're working with helping the woman manage the pain of birth, and this is an important aspect of the nursing care in the childbearing woman. The nurse who has never given birth may feel inadequate to care for women who are laboring, but as nurses, many times we have never experienced medical conditions such as fractures, strokes, heart attacks, etc. But we are competent to care for these patients with these medical conditions. So it should be noted that we are also trained to care for women in their labor, and we are nurses, so it doesn't necessarily mean that we have to experience the condition in order to competently care for the patient in the condition. Nurses are trained to care for patients and do not need to have experienced the medical condition themselves in order to be competent in doing so. Nursing skills needed by the intrapartum nurse are basic: the observation process, the critical thinking process, problem solving, therapeutic communication, comfort promotion, empathy, and common sense. Nurses may be anxious due to their personal experiences during labor that may have been difficult too. So if you've given birth and it was difficult, it may bring back those feelings of that time in your life. But every woman, every pregnancy, every delivery is different. So it is important for the nurse not to convey negative attitudes to the laboring woman and her partner, because it may not be a negative experience for them, and we don't want to spoil that for them, so to speak. Labor is a natural process that is individual, and it follows its own timetable. Some nurses find the unpredictability troubling, and some find it exciting. Some days are busy and some are quiet. The intimate nature of intrapartum care and the sexual overtones make some nurses uncomfortable. Sometimes it feels that nurses are intruding on a private time of the couple. The male nurse many times finds it awkward to care for an intrapartum woman for many reasons, and they may wonder how the woman and her partner will feel about a male nurse caring for her during this time. It's important for all nurses to maintain professional conduct and to take cues from the couple. If they wish to have privacy, the nurse should intervene only as needed to access the woman and the fetus. During advanced labor, however, both partners welcome the presence of a competent, caring nurse or either a male nurse or a female nurse. It's not going to matter as long as the nurse is competent and willing to help them. Labor and birth affect the physiologic systems of both the pregnant woman and her fetus. These effects are most striking in the maternal reproductive system and in relation to fetal and neonatal oxygenation. Significant changes occur during labor in the woman's cardiovascular, the respiratory, the gastrointestinal, the urinary, and the hematopoietic system, as well as in her reproductive system. So let's look at the reproductive system first. Normal labor contractions are coordinated, involuntary, and intermittent. Coordinated contractions is where the uterus can contract and relax in a coordinated way, as can other smooth muscles such as the heart. As a woman approaches full term, contractions become organized and gradually assume a regular pattern of increasing frequency, duration, and intensity during labor. Coordinated labor contractions begin in the uterine fundus, the top of the uterus, right at the very top of the rib cage, and they spread downward toward the cervix to propel the fetus through the pelvis. They are involuntary contractions. Uterine contractions are not under conscious control, as are skeletal muscles. The mother cannot cause labor to stop or start by conscious effort. Walking or other activity may stimulate existing labor contractions. Anxiety, however, and excessive stress can diminish the laboring process. So laboring tends to be more difficult when women are under stress or they're very anxious. So we don't want that to happen. Intermittent contractions. Labor contractions are intermittent rather than sustained, allowing relaxation of the uterus smooth muscle and resumption of blood flow to and from the placenta to permit the gas, the nutrients, and waste exchange for the fetus. There is what we call a contraction cycle. Each contraction consists of 3 phases. The increment occurs as the contraction begins in the fundus and spreads throughout the uterus. The peak, or the acme, is the period during which the contraction is most intense. The decrement is the period of decreasing intensity as the uterus relaxes. The contraction cycle and the overall pattern of contractions are also described as in terms of frequency, duration, and intensity. Frequency is a period from the beginning of one uterine contraction to the beginning of the next, and it is usually expressed in minutes and fractions of minutes. For example, the nurse states contractions are 3 1/2 to 4 minutes apart. Duration is the length of each contraction from beginning to end. It is usually expressed in seconds. For example, the nurse might report that a patient's contractions are lasting 55 to 65 seconds. The intensity is the strength of the contraction, and the term mild, moderate, and strong are used to describe the contraction's intensity as palpated by the nurse. Mild contractions are often described as feeling like the tip of the nose. Moderate contractions are like the chin, the feeling of when you touch your chin. That's what a moderate contraction feels like on the woman's belly. And then firm contractions are like the forehead, very, very hard, very firm. So different descriptions of intensity may apply when the internal electronic fetal monitor is used to record contractions. The interval is a period between the end of one contraction and the beginning of the next. The interval is a time when most fetal exchange of oxygen, nutrients and waste products occurs, and this is also called the resting tone. Uterine body, the uterine activity during labor is characterized by opposing features. The upper 2/3 of the uterus contracts actively to push the fetus down, and the lower 1/3 of the uterus remains less active, allowing downward passage of the fetus. The cervix is similar to the lower uterine segment in that it allows passive, it is also passive, it allows the fetus to pass through. And the next effect of labor contraction is enhanced because the downward push from the upper uterus is accompanied by reduced resistance to fetal descent in the lower uterus. The myometrial, or the uterine muscle, cells in the upper uterus remain shorter at the end of each contraction rather than returning to their original length. And in contrast, myometrial cells in the lower uterus become longer with each contraction. And these two characteristics enable the upper uterus to maintain tension between contractions to preserve the cervical changes and downward fetal progress made with each contraction. The opposing characteristics of myometrial contractions in the upper and lower uterine segments cause changes in the thickness of the uterine wall during the labor, and the upper uterus becomes thicker while the lower uterus becomes thinner and pulled upward during labor. And this physiologic retraction ring marks the division between the upper and lower segments. The opposing characteristics of contractions in the upper and lower uterine segments change the shape of the uterine cavity, which becomes more elongated and narrower as labor progresses. And this change in uterine shape straightens the fetal body and efficiently directs it downward in the pelvis. Now, the cervical changes that occur are called effacement and dilation. And effacement means a thinning and shortening of the cervix, and dilation is the opening of the cervix. And there are major cervical changes during labor. These two are major cervical changes. Effacement and dilation occur together during labor, but not at the same time, at different rates. The nullipara, or the woman who has never had a baby, completes most cervical effacement early in the process of cervical dilation. In contrast, the Paris means that they've had at least one baby, maybe more. The Paris woman's cervix is usually thicker than a nullipara's cervix at any point during labor. Effacement, before labor, the cervix is a cylindric structure. It looks like a cylinder, approximately 2 centimeters long at the lower end of the uterus, and labor contractions push the fetus downward against the cervix as they pull the cervix upward. The cervix becomes shorter and thinner as it is drawn over the fetus and amniotic sac. The cervix merges with the thinning lower uterus rather than remaining a distant cylindric structure, and effacement is estimated as a percentage of the amount the cervix has thinned, so that a fully thinned cervix is 100% effaced. So effacement also may be recorded as cervical length, estimated in centimeters during vaginal examination. Dilation is as the cervix is pulled upward and the fetus is pushed downward, the cervix dilates. Dilation is expressed in centimeters, with approximately 10 centimeters being full dilation, large enough to allow passage of an average size term fetus. The action during effacement and dilation can be likened to pushing a tennis ball out of a cuff of a sock. Now, the cardiovascular system, during each uterine contraction, blood flow to the placenta gradually decreases, causing a relative increase in the woman's blood volume, and this temporary change increases her blood pressure slightly and slows her pulse. Therefore, the mother's vital signs are best assessed during the interval between contractions. And that is important. And so supine hypotension is most likely to occur during the antepartum period because the fetus has not yet started to descend, but also may occur during labor if the mother lies on her back. The mother should be encouraged to rest in positions other than the supine position to promote blood return to her heart and therefore enhance blood flow to the placenta and promote fetal oxygenation. So, in other words, if she's lying on her back all the time and not moving on her side or propping her hip to one side, it could cause compression of the vena cava, and then it could cause decreased oxygenation to the fetus ultimately. Fetal responses are, notable most in the placental circulation, the cardiovascular system, and the pulmonary system. Placental circulation involves an exchange of oxygen, nutrients, and waste products between the mother and the fetus, and it occurs in the intervillous spaces. During strong labor contractions, the maternal blood supply to the placenta stops intermittently as the spiral arteries supplying these spaces are compressed by the uterine muscles. For this reason, most placental exchange occurs during the interval between contractions. The placental circulation usually has enough reserve over fetal basal needs to tolerate this intermittent interruption of blood flow. The fetus has protective mechanisms such as fetal hemoglobin that more readily takes on oxygen and releases carbon dioxide, a high hematocrit, and a high cardiac output. The fetus may not tolerate labor contractions well in conditions where the placental function is reduced, such as maternal diabetes or hypertension, or in conditions associated with reduced fetal oxygen carrying capacity, such as with fetal anemia. Cardiovascular system. The fetal cardiovascular system reacts quickly to events of labor. The fetal heart rate is rapid, and it is the average is 110 to 160 beats per minute, and the preterm fetus may have a slightly higher heart rate than the term fetus. Pulmonary system. Before birth, the fetal lungs are filled with fluid to allow normal development of the airways. This fluid must be cleared to allow for air breathing. As term approaches, the production of the fetal fluid decreases and absorption increases. Labor intensifies the absorption of lung fluid, and some fluid is expelled from the upper airways as the fetal head and thorax are compressed during the passage through the birth canal. The remaining fluid is absorbed into the newborn's pulmonary and lymphatic circulation after birth. The four major factors called the 4 P's interact during normal childbirth, and this is the powers, the passage, the passenger, and the psyche. And we'll talk about the powers. The 2 powers of labor are uterine contractions and maternal pushing efforts. Uterine contractions happen during the first stage of labor, the onset through full cervical dilation. Uterine contractions are the primary force moving the fetus through the pelvis. Maternal pushing efforts. During the second stage of labor, full cervical dilation through the birth of the baby, the woman adds her voluntary pushing efforts to the force of uterine contractions to propel the fetus through the pelvis. And then the passage. The passage for birth of the fetus consists of the maternal pelvis and the soft tissues. The bony pelvis is usually more important to the outcome of the labor than the soft tissue because the bones and joints do not readily yield to the forces of labor. Softening of the cartilage linking pelvic bones increases as term approaches and the hormone relaxin increases. The bony pelvis is divided by the linea terminalis or pelvic brim into the false pelvis above the true pelvis below. The true pelvis is most important in childbirth. The true pelvis has three subdivisions: the inlet or upper pelvic opening, the mid-pelvis or pelvic cavity, and the outlet or lower pelvic opening. The true pelvis is like a curved cylinder with different dimensions at different levels. The passenger is the fetus plus the membranes and the placenta. The fetus enters the birth canal in the cephalic presentation about 96% of the time. The fetal shoulders are important because of the width. The shoulders will usually flex and adapt to the pelvis. The bones of the fetal head are the two frontal bones of the forehead, the two parietal bones of the crown of the head, and the occipital bone. These five major bones are not fused, but are connected by sutures that are strong and flexible fibrous tissues. The fontanelles are wider spaces in the intersections of the sutures. The anterior fontanelle is a diamond shape formed by two coronal, frontal, and sagittal sutures connecting the frontal and parietal bones. The posterior fontanelle has a triangular shape and is formed by sagittal and lambdoid sutures connecting two parietal bones and the occipital bone. This fontanelle is very small and can move slightly to change the shape of the head so as to adapt to the size and shape of the pelvis by molding. The fontanelles provide landmarks also to determine fetal position and head flexion during vaginal examination. Most fetuses enter the pelvis in the cephalic presentation, but several variations are possible. The average measurement between the two parietal bones of the infant head is 9.5 centimeters in term fetuses. The anterior-posterior diameter varies with the degree of flexion. It is most favorable when the fetal head is fully flexed during labor and the anterior-posterior diameter is the suboccipitobregmatic position, averaging 9.5 centimeters. And you can look at figure 16.5b for different degrees of head flexion and extension. Fetal lie is the orientation of the long axis of the fetus to the long axis of the woman, and in more than 99% of pregnancies, the lie is longitudinal or parallel to the long axis of the woman. With the longitudinal lie, either the head or buttocks enters the pelvis first. In a transverse lie, the long axis of the fetus is at right angle to the woman's long axis, and this orientation occurs in less than 1% of pregnancies, and a fetus in an oblique lie is at an angle between the longitudinal and the transverse lie. The attitude of the fetus is a relation of the fetal parts to each other. The normal fetal attitude is flexion, and that is with the head toward the chest and arms and legs flexed over the thorax. The back is curved in a convex C shape as labor begins. Presentation falls into the following categories: 1 cephalic, 2 breech, and 3 shoulder. Cephalic is most common. Other presentations are associated with prolonged labor or other problems and require C-section. Cephalic presentations are more favorable because, number 1, the fetal head is the largest fetal body part, and after the head is born, similar parts follow easily as extremities unfold. And the second reason is during labor, fetal head can gradually change shape to adapt to the maternal pelvis. And the third reason is that the fetal head is smooth, round, and hard, making it effective in allowing the cervix to dilate, which is the cervix is also round. Cephalic presentation has 4 variations. Number 1 is a vertex, where the fetal head is fully flexed. And again, this is most desirable because the smallest suboccipital-brachmatic diameter is presenting. And number 2 is the military, also called the synciput, where the head is in the neutral position, neither flexed nor extended. This is normally a temporary position because the head will flex during the delivery. And then number 3 is the brow, and this position is where the fetal head is partially extended. The longest supraoccipital diameter is presenting. And number 4, face head. Number 4 is the face. The head is fully extended and the fetal occiput is near the fetal spine. The submental brachmatic diameter is presenting. And then with the breech presentation, the fetal presentation occurs when the buttocks or the feet enter the pelvis first. This occurs in about 3% of births, and there are several disadvantages to a breech birth. Buttocks are not smooth and firm like the head. They are less effective at dilating the cervix. And the fetal head is last in these positions. The fetal head comes last and is the last part to be born. The umbilical cord is subject to compression between the baby's head and the maternal pelvis. So all of those reasons are not good reasons are the reasons that you should not you should not desire a breech birth. Also, the umbilical cord can be compressed after the fetal chest is born, and the head must be delivered quickly to allow infant to breathe. The necessary speed does not allow gradual molding of the fetal head as it passes through the pelvis. So all of those things are just cause a difficult delivery for breech births. A frank breech is the most common breech position where legs are extended across the abdomen toward the shoulders. You can have a full or a complete breech. The head and knees and hips are flexed and buttocks are the presenting part. A footling breech is when one or both feet present first, and a shoulder position is when the shoulder presentation is a transverse lie and accounts for less than 1% of births, and this is usually a preterm birth, and C-sections are necessary with this presentation. The position describes the location of a fixed reference point of the fetal reference point. Is right or left of the mother's pelvis. You can look at figure 16.10 on page 300, and then the first letter describes the fetal reference point that is either right or left of the mother's pelvis. If it's neither right or left, this letter is omitted, and then the second letter refers to a fixed fetal reference point. Occiput is O, mentum is M, and sacrum is S. And then number 3, anterior or posterior or transverse. The third letter describes whether the fetal reference point is anterior or posterior quadrant of the mother's pelvis. If the fetal reference is neither anterior or posterior, it will be a T for transverse. Psyche is a crucial part of childbirth. Marked anxiety, fear, or fatigue decreases the woman's ability to cope with the pain of labor. Maternal catecholamines secreted in a response to anxiety or fear can inhibit uterine contractility and placental blood flow. Relaxation augments the natural process of labor, so relaxation is a very, very important part of the labor for the woman. The 4 P's are an interrelated whole. For example, a woman with a small pelvis and a large fetus can have a normal labor and birth if the fetus is positioned and the uterine contractions and maternal bearing down efforts are vigorous. The nurse can support the mother to be through a positive attitude that enhances the process of birth. and the nurse advocates for the woman and her family. So all of that is very important, and for most nurses, it is very, very meaningful and a very gratifying experience. Culture shapes the woman's values held and the expectations of the birthing experience and the woman's response to birth. It is helpful to the nurse to have knowledge of the values and practices of cultural groups. Page 300 gives guidance for this, and childbirth is a physical and emotional experience. The event changes a woman and her family forever. Nursing measures that increase a sense of control and mastery during birth helps families to perceive birth as a positive event. Changes in the ratio of maternal estrogen to progesterone, so the estrogen levels are higher than progesterone levels, reducing the relaxant effects of progesterone on the uterine muscle. Relatively higher estrogen levels near the onset of labor enhance uterine sensitivity to substances that stimulate uterine contractions. Prostaglandins from fetal membranes and oxytocin from the maternal posterior pituitary gland. Estrogens increase the number of gap junctions, which are connections that allow individual uterine muscle cells to contract as a coordinated unit. Prostaglandins produced by the decidua and membranes may have a role in preparing the uterus or oxytocin stimulation at term. Prostaglandins are secreted from the lower area of the fetal membranes during labor and may reflect inflammation caused by contact with microorganisms from the woman's vagina. Increased secretions of natural oxytocin appears to maintain labor once it has begun. Oxytocin alone does not appear to start labor, but may play a part in labor's initiation in conjunction with other substances. Evidence of fetal oxytocin secretion also exists. Oxytocin receptors in the uterus increase markedly as labor begins, and the increase continues during labor and peaks at delivery. Oxytocin has little effect on the uterine muscles if the receptors have not developed. The fetal role in the initiation of labor is thought to be a factor. The fetal membranes release prostaglandin in high concentration during labor. Fetal oxytocin secretion and large quantities of cortisol are secreted by the fetal adrenal glands and possibly act as a uterine stimulant. Stretching, pressure, and irritation of the uterus and cervix increase as the fetus reaches full-term size. A feedback loop is thought to be responsible for labor contractions at term. The fetal head stretches the cervix, causing the fundus of the uterus to contract, and it pushes the fetal head against the cervix and causes more fundal contractions. Cervical stretching also causes secretion of oxytocin. Before spontaneous labor begins, women usually notice one or more premonitory or warning sign that labor is near. Braxton Hicks contractions are irregular, mild contractions that occur throughout pregnancy and increase in frequency and are sometimes painful. And these may become regular at times only to decrease spontaneously. Lightening or dropping occurs as the fetus descends toward the pelvic inlet. Lightening is most noticeable in nulliparas occurring approximately 2 to 3 weeks before the onset of labor. Increased, clear, and non-irritating vaginal secretions occur as fetal pressure causes congestion of the vaginal mucosa. Bloody show is a mixture of thick mucus and pink or dark brown blood and may occur as the cervix begins to soften, dilate, and efface slightly, or this is called ripen. An energy spurt occurs, and this is known as nesting. The woman is getting ready for the baby to be born, so she gets a lot of energy and she starts to prepare her home for the baby. maybe organizing baby clothes, organizing the nursery, getting ready for the baby to be a part of her home. So a small weight loss of 2.2 kilograms to 6.6 kilograms, and this is 1 to 3 pounds, may occur because of changing levels of estrogen and progesterone, and that they cause excretion of some of the extra fluid that accumulates during pregnancy. False labor or prodromal labor is common because of the time of spontaneous labor's onset is rarely known, and the onset is usually gradual. False labor also causes women to be disappointed when their symptoms are not true labor. The false labor is simply a preparation for the true labor, and several characteristics distinguish true labor from false labor. And these are contractions, discomfort, and cervical change. The best distinction between the two is that contractions of true labor causes progressive changes in the cervix. Effacement and dilation occur with true labor contractions. And sometimes when Braxton Hicks contractions occur, they'll have the woman to walk. And if the walking progresses the labor, then that's true labor. If the walking stops the labor, then that's false labor. So with false labor, contractions are inconsistent in frequency, duration, and intensity, and the change in activity does not alter contractions. For discomfort, this is felt in the abdomen and growing, more annoying than painful. In the cervix, there is no significant change in effacement or dilation in the cervix. And with true labor, the contractions are consistent. They're a consistent pattern with increasing intensity, duration, and frequency. Walking increases the intensity, as I said earlier. What many of the labor and delivery nurses will do is when a woman presents to the laboring unit and she's thought to be in labor, they'll have her walk. And if the walking increases the labor and it doesn't stop it, then they know it's true labor. With true labor, the discomfort begins in the low back and then it wraps around to the abdomen usually. And the cervix does begin to, the effacement continues and dilation occurs. And so once the dilation occurs with nulliparous women, it may take a good while. With parous women, it may not take that long at all. So for the dilation to occur, so it's just different situations with different women, depending on their history. The mechanisms of labor occur as the fetus is moved through the pelvis during birth. The following position changes occur to adapt to the size and shape of the mother's pelvis at different levels. Although the mechanisms of labor are described separately in your text, many times they occur concurrently. In a vertex presentation, these mechanisms are for the descent, the fetal presenting part through the true pelvis, the engagement of the fetal presenting part as its widest diameter reaches the level of the ischial spines of the mother's pelvis, the flexion of the fetal head so that the smallest head diameter passes through the pelvis first, and the internal rotation to allow the largest fetal head diameter to match the largest maternal pelvic diameter, the extension of the fetal head as it passes beneath the mother's symphysis pubis, the external rotation of the fetal head to allow the shoulders to rotate internally to fit the mother's pelvis, the expulsion of the fetal shoulders and then the fetal body, and the mechanisms of labor are different in presentations other than vertex, but the reason is the same. the effective use of available space in the maternal pelvis. So you can look at figure 1612 in the textbook, and it takes you through all of the mechanisms of labor per the presentations that are possible. Each stage and phase of labor has qualities that set it apart from the others. Individual women vary in labor patterns and responses to labor. Table 16.1 provides details of the characteristics of each stage of labor. Use of regional anesthetics such as the epidural block is likely to modify the typical maternal behavior. Also, labor that is induced or augmented often differs from spontaneous labor. The first stage of labor is when the cervical effacement and dilation occur in the first stage, and this begins with the onset of true labor contractions and ends with complete dilation of 10 centimeters dilation and 100% effacement of the cervix. The first stage of labor is the longest for nulliparous and parous women. The plotted graph of the first stage of labor is called the Friedman curve. Fetal monitoring provides information about whether a longer labor should be ended or allowed to be continued. The first stage of labor has 3 stages or 3 phases, and those are the latent, the active, and the transition. And these phases are characterized by maternal behaviors which vary with the woman's preparation, such as childbirth classes, also use of coping skills, and what analgesia she is given, whether it be the epidural block or others. And latent phase or early phase lasts from the beginning of labor until 3 to 5 centimeters of cervical dilation. Its length varies among women. Despite being called latent, cervical effacement and fetal position change occur during this phase, which prepare for the more rapid changes of active labor. The woman is usually sociable and excitable during the early phase of labor. The active phase of labor is when the cervix dilates more rapidly, between 4 and 6 centimeters. Effacement and dilation of the cervix are completed. Internal rotation occurs in the fetus as the fetus descends in the pelvis during the active labor. The discomfort increases. Transition may be used to describe the intense contractions of fetal descent. The fetus descends in the pelvis during active labor. Discomfort increases, and then the transition may be used to describe the intense contractions of fetal descent and final cervical dilation, approximately 7 or 8 centimeters to complete 10 centimeters. Bloody show increases with the completion of dilation. Transition is short but intense with very strong contractions, and the woman may have an urge to push down during contractions as the fetal presenting part reaches her pelvic floor. Leg tremors, nausea, and vomiting are common as the second stage nears. The woman becomes more anxious and may feel irritable and helpless as the contractions intensify during this time. And the woman is now serious, and she has an inward focus at this time. She's no longer chatty, and all of that has passed, so she's just focusing inward. The second stage of labor begins with a 10 centimeters dilation and a full 100% effacement of the cervix, and it ends with the birth of the baby. The fetus descends. Pressure of the presenting part is on the rectum and the pelvic floor and causes the mother to have an involuntary pushing response. She may say she needs to have bowel movement or that the baby is coming. She may say, I have to push. Her voluntary pushing efforts augment involuntary uterine contractions, and as the fetus descends low in the pelvis and the vulva descends with crowning of the fetal head, the mother may feel a sensation of stretching or burning. Contractions will be strong, and the woman may feel more in control because she is now pushing with these labor contractions. Labor is a good description of the second stage. The woman will exert intense efforts to push her baby out. Between contractions, she may notice her surroundings and even She may not notice her surroundings and even appear to be asleep. She's so focused. So she feels tremendous relief and excitement as the second stage ends with the birth of the baby. And then the third stage, or placental stage, begins with the birth of the baby and then ends with the expulsion of the placenta. When the infant is born, the uterus cavity becomes smaller and the reduced size decreases the size of the placental site, and this causes the placenta to separate from the uterine wall. And 4 signs that the placenta has separated is, number 1, the uterus has a spherical shape. The uterus rises upward in the abdomen as the placenta descends into the vagina, and this suggests placenta separation. The fundus is all of this pushes the fundus upward. The cord descends further from the vagina. A gush of blood appears as the blood trapped behind the placenta is released. The placenta may be expelled in the more common Schultz mechanism, where the placenta is expelled with a shiny fetal side first, and the Duncan mechanism is less common, with the rough maternal side presenting. The uterus must contract firmly and remain contracted after the placenta is expelled in order to compress the open vessels at the implantation site in the uterus. Inadequate uterine contractions after birth may result in a hemorrhage. Pain during the third stage of labor results from uterine contractions and brief stretching of the cervix as the placenta passes through it. And then the fourth stage of labor is the stage of physical recovery for the mother and the infant, and it lasts from delivery of the placenta through the first 1 to 4 hours after birth. Immediately after birth, the firmly contracted uterus can be palpated through the abdominal wall as a firm, rounded mass of 10 to 15 centimeters, 4 to 6 inches in diameter, at or below the level of the umbilicus. The uterus is larger when the infant is large or the mother is a multipara, having more than one baby, over her childbearing years. She's had several, maybe. Uterine size is larger in women who deliver twins, of course, and vaginal drainage during the fourth stage is logia rubra, and that consists mostly of blood. It's bright red. Small clots may be present. Many women have a chill after birth, approximately 20 minutes, and warm blankets, hot drinks, or soup may help to shorten this chill and increase the woman's comfort. Discomfort during the fourth stage usually results from birth trauma or after pains. Ice packs on the perineum limit discomfort and hematoma formation. After pains are uterine contractions that are similar to menstrual cramps that occur after birth as the uterus begins to return to the pre-pregnancy state. And these are more intense in multiparas, in women who breastfeed, in women who had large babies or other causes of uterine overdistension during pregnancy, or when something interferes with uterine contractions, such as a full bladder or blood clot that remains in the uterus. So full bladders are something that the nurse can encourage the women to urinate, to go ahead and void and get rid of the full bladder to increase their comfort. The mother is very tired and excited after the birth of her baby. She may be exhausted but too full of nervous energy to rest, and this is an ideal time for the family and the maternal infant bonding to begin, because the interest of both parents and the newborn is very high. And this is also the best time to begin breastfeeding. And if no maternal or infant problems are present, she can breastfeed the baby, put the baby to the breast, and that helps the uterus contract and get to the normal size sooner. The baby is usually alert and seeks to make eye contact with the new parents, and this is a powerful reinforcement for the parental attachment to the infant. And you can also see figure 1613 in your textbook to reinforce this information. The total duration of labor differs between women who have never given birth and those who have previously given birth vaginally. The Paris woman usually delivers more quickly. However, women are individuals, and some nulliparas will progress through labor quickly, and some Paris women may resemble women who have never given birth. So a woman who had a long labor with her first child may not have a long labor with every baby. Women who delivered first babies quickly will likely deliver next babies quickly. During the last semester, a woman needs to know when she should go to the hospital or birth center. I need you to look at the box on patient-centered teaching that talks about when to go to the hospital or birth center. A pattern of increasing regularity, frequency, duration, and intensity of contractions. For nullipara, regular contractions 5 minutes apart for 1 hour. For multipara, regular contractions 10 minutes apart for 1 hour. Anytime a woman has ruptured membranes, which is like a gush of or a trickle of fluid from the vagina, should be evaluated. So whether or not the woman is having contractions, if her water is broken, she needs to report to the birthing center or the hospital. Bright red bleeding that is not mixed with mucus should be evaluated promptly, so she would need to go to the hospital or the birth center for that as well. Normal bloody show is thicker, pink, or dark red and mixed with mucus. Decreased fetal movement, that is another reason for the woman to seek help. If the woman notices a decrease in the baby's movement, she should notify her physician or nurse midwife or go to the labor unit. And these guidelines cannot cover all situations, but sometimes women just know something is wrong and they should be advised to report to the birth center or the hospital. Many times women don't really have a clear description of what is going on, but they know something's wrong. And so most of the time when they know something's wrong, there is something wrong. Nurses teach women about the differences between false and true labor and offer guidelines for going to the birth center. And every woman will not have a typical labor. So a woman should be encouraged to go to the birth center if she is uncertain or has concerns. The nurse has two priorities when the woman arrives at the birth center, and number one is to establish a therapeutic relationship with the patient. Number two is assessing the condition of the mother and the fetus. Make the family feel welcome. The nurse should communicate interest, friendliness, caring, and competence. Families understand if the nurse is very busy, but they do not understand rudeness or insensitivity to their needs. When caring for a woman who has not gone for prenatal care and or childbirth classes, the nurse should avoid a judgmental attitude in words or actions. The woman deserves respect, support, and care of any other, just as much as any other woman. So arrange for interpreters for those women who speak another language. If an interpreter is not on site, a telephone interpreter should be available. Family members as interpreters are not normally acceptable per hospital policy. The nurse should determine the family's expectations about birth. Some women or parents may have a written birth plan filled with their prenatal records. Those who have not made specific plans also have expectations. Most women assume the baby's father will attend the birth. Many women will expect other close family members to be present as well. The nurse should convey confidence in the woman's ability to give birth, as well as her partner's ability to support her during the birth. A primary nurse should be assigned as much as possible. And using touch for comfort can communicate acceptance and reassurance and can comfort the woman. Even women who do not usually welcome touch can appreciate it during labor. As labor progresses, touch may become an irritant rather than a comfort measure during labor, and cultural beliefs and practices give structure and meaning to the birth experience. The nurse should incorporate cultural practices as much as possible. The intrapartum assessment guide is on page 309 to 313. The assessment includes the patient interview, fetal evaluation, labor status, and physical examination. Please read and be very familiar with this, pages 309 to 313. Thank you. Again, these are guidelines for when the mother to be would report to the hospital. A box on page 308 features this information. So contractions is defined as a pattern of increasingly regular intensity, duration, and frequency. Ruptured membranes is a gush or trickle of fluid from the vagina should be evaluated. Bleeding, bright red bleeding that is not mixed with blood or mucus should be evaluated. Additional information for when to report to the hospital is on this slide. Decreased fetal movement. A decrease in baby's movement should always be evaluated. Many times the obstetricians will advise women if they notice the baby's not moving a lot, they'll advise them to drink maybe some juice or water and then lay still for a little bit and count the baby's kicks and document that on maybe a journal and bring it to the physician's office when they come. And they advise them to do that frequently, maybe every day or several times a day. Other concerns, seek treatment for any concerns or feelings that something may be wrong. Again, many times if there's something wrong, the mother will just know that there's something wrong and they can sense that. And so we encourage them to do that. Maternal positioning is the most common measure to promote placental function during normal labor, and the woman can choose any position other than supine to avoid aorta caval compression that would reduce blood flow to the placenta. If she must be in the supine position for a procedure such as a catheterization, a small pillow or rolled towel or blanket wedged under one hip shifts the uterus to one side to maintain good placental blood flow. And the nurse will observe for conditions associated with fetal compromise, determine whether any conditions associated with fetal compromise exist, and if these are identified, assess the fetus more frequently and notify the birth attendant. Recognizing cues related to fetal oxygenation, refer to the assessment listed in Table 16.2 for intrapartum cues. And the main cues are the fetal heart rate, the contraction frequency, the duration, the intensity, the resting tone, and the interval. The character of the amniotic fluid, the amount and time of rupture, if her waters have broken, and then of course the maternal vital signs. And again, we talked about when to take the vital signs of the mother to be, and that is between contractions. These findings would be cause for concern. Fetal heart rate outside normal range of 110 and 160 beats per minute, meconium stained amniotic fluid, cloudy yellowish or foul odor to the amniotic fluid, excessive frequency or duration of the contractions, incomplete uterine relaxation, maternal hypotension or hypertension, and a maternal fever of 38 degrees Celsius or 100.4 degrees Fahrenheit or higher. These considerations will be taken in order to promote comfort for the laboring woman. You can also look on figure 1615 in your text. Um, and these measures promote the woman's ability to relax and cope with labor. Lighting and temperature make sure that they are the way that the woman wants them to be. Cleanliness and mouth care are important. Bladder, positioning, water, hydration, providing encouragement, and pharmacologic pain relief. The nurse must be alert for signs of impending birth. The mother will always say, the baby's coming, because she can feel the baby coming. And also grunting sounds of the woman. The woman is bearing down. She feels a need to bear down. And then the nurse should check the perineum for the presenting part of the baby, because many times the baby comes quick. And it's always a nursing action is to check the perineum. The nurse has added responsibilities during the birth, and in most cases there will be other professionals in attendance that will assist. The most important responsibilities include preparation of a table with sterile gown, gloves, drapes, solutions, and instruments, and the perineal cleansing preparation, preparation for initial care and assessment of the newborn, including calling neonatal staff if indicated, and the administration of medications such as oxytocin to contract the uterus and control blood loss. Intrapartum nursing care extends through the fourth stage of labor and includes care of the infant, the mother, and the family unit. Immediate care of the newborn includes supporting cardiopulmonary and thermoregulatory function and placing identifying bands on the infant and the mother. The nurse assesses the infant for approximate gestational age and whether the infant is large or small for gestational age. Assessment of the blood glucose level is common for infants at increased risk for hypoglycemia, such as those large or small for gestational age, and infants of mothers with diabetes. Assessment for obvious anomalies or birth injuries and number of cord vessels should be completed as well. A stable newborn should be placed skin to skin with mother immediately following the delivery. A full admission assessment and bath can be done following an hour of skin to skin contact as long as the infant is stable. Care of the mother during the fourth stage of labor focuses on observing for hemorrhage and relieving discomfort. I want you to be prepared to know the information on table 16.4, which summarizes possible problems for the mother during the fourth stage. For the assessment for hemorrhage, take vital signs. Note the uterine fundus, bladder, and lochia. The temperature should be taken and continue temperature assessment for the woman who requires extended recovery periods. Assess blood pressure, pulse, and respiration every 15 minutes during the first hour and every 30 minutes to 1 hour after the first hour, or as indicated by her condition. Evaluate the need for pain medication. A rising pulse is an early sign of excessive blood loss because the heart contracts faster to compensate for reduced blood volume. The blood pressure may fall much later as the blood volume is severely reduced with hemorrhage. A rising pulse rate also accompanies an elevated temperature. If the woman has an indwelling catheter, observe her urine output. A low urine output of less than 25 to 30 milliliters per hour identifies water conservation by the kidney in response to falling blood volume from excess bleeding or dehydration. The most common reason for excessive postpartum bleeding is that the uterus does not firmly contract and compress open vessels at the placental site. Assess for firmness, height, and positioning of the uterus, of the uterine fundus with each vital sign assessment. The fundus should be firm in the midline and at or below the umbilicus. It is approximately the size of a large grapefruit. If the fundus is firm, no massage is needed. If it is soft or boggy, massage the fundus until it is firm. Nipple stimulation from the infant breastfeeding will release natural oxytocin from the mother's posterior pituitary to maintain firm uterine contraction. Oxytocin in the intravenous solution or given IM has the same effect. A full bladder interferes with contractions of the uterus and may lead to hemorrhage. The nurse would suspect a full bladder if the fundus is above the umbilicus or is displaced to one side, usually the right side. The woman can ambulate to the restroom unless there are contraindications, and the first 2 or 3 voidings are measured until it is evident that the woman voids without difficulty and the bladder is emptied completely, and that is usually 300 to 400 milliliters. Logia should be assessed with each vital sign and fundal assessment. Saturation of one pad during the first hour after delivery is the maximum normal logia flow. Observe for logia that pools under the buttocks and back, and the presence of large clots is not normal. The physician or midwife would be notified if that is a finding. A continuous trickle of bright red blood when the fundus is firm suggests a laceration in the birth canal. A hematoma causes bleeding into tissue, but excess visible bleeding is unusual. Relieving discomfort. Uterine contractions and perineal trauma are common causes of pain after birth. A postpartum chill can also occur. Pain is usually mild and relieved by simple measures. Intense pain that is not remedied by common pain relief measures should be investigated, and the birth attendant should be notified. Ice packs are applied to the perineum after vaginal birth, and this can be used to reduce edema and limit hematoma formation. Sometimes a diaper filled with ice, because it is economical, more absorbent, and colder than the pads with cold packs, is used. As for analgesics, after pain and perineal pain respond well to mild oral analgesics such as ibuprofen. Irregular urination will reduce the severity, regular urination will reduce the severity of after pains. Remember, a full bladder can also cause the uterus to be displaced, and that could cause some discomfort as well. Warm blankets is soothing and shortens the chill that is sometimes there after birth, is sometimes common after birth. So all of those things, know these things and remember them for your woman who has delivered. The first hour after birth is the ideal time for parent-infant attachment because at this time the healthy neonate is alert and responsive. The nurse should ensure that the family has privacy while unobtrusively observing the parents and infant. The infant can remain in the parent's arms while the vital signs are taken or while mild suctioning of secretions and many initial assessments are being completed for the newborn. The nurse can assist the mother to nurse during the recovery period if the mother desires. The infant is usually attentive and nurses briefly. Nipple stimulation initiates milk production. When the parents are ready, allow the siblings and other family members and friends to visit. Help siblings to see and to touch their new brother or sister by placing a stool beside the bed or letting them sit on the bed. Expect parents to speak to their baby with high-pitched, affectionate tones. Cultural norms should be accepted for the population that is being cared for. And so you need to consider your cultural norms and consider, the various ethnic backgrounds that we're caring for in our hospital settings where you are. And that is the end of this presentation. Thank you so much, and I look forward to seeing you in class.